Okay. Good afternoon, everyone. I would like to thank the organizers to give us the opportunity to share our experience in the Meenakshi Mission Hospital. We have been running this telemedicine for the last 3 years. And this is, I would say, a small success story, what we have just started our journey in telemedicine. I'm going to share some of our experiences, not from the technology perspective, but from the user perspective and from the people perspective, and what we are going to see that. Let me give a brief introduction about the hospital. Our hospital is a 650-bedded hospital, and which is run by SR Trust in the city of Madurai. And we have all the specialities, around 300 full-time doctors and around 2,000 staff, full-time staff. Okay, how I'm going to look, I'm going to go through how the Meenakshi Telecare functions, some of our observations and key challenges which we have seen over the last 3 years. That's what we think we are going to see, and how we can overcome it. It's left to us how we decide upon that. Okay, I'm not going to go to the problem, which we all know, and why technology, we all know because of short of time. I need to tell you about how the genesis of this started. The driving vision for this Meenakshi Telecare project is because of the vision which we have is no man is too poor to access the first grade medical treatment. I think the sentence really explains what it is. And we have a vision and a mission for world-class care within everybody's reach. This really is the driving force which we started the telemedicine project in the year 2008. Especially, I would really thank ISRO and Mr. Satyamurthy, who really initiated us to start with this by providing us the satellite connectivity. And first, we started with the mobile telemedicine, and then we went on to the static telemedicine in the rural centers. Our goal is to provide comprehensive quality health care in the rural Tamil Nadu. We have high ambitions of starting around 500 to 600 centers all over Tamil Nadu within year 2015. Let's see how we are good. Our objective of this project, where we provide multi-specialty healthcare services through mobile telemedicine, rural health centers all over, quality diagnostic and laboratory services, public health, continuing medical education, and information education communication program. Okay, why is this MDG goals? By doing this project, we are at least reaching 5 of the MDG goals. We are just touching upon it. We have not reached completely. I will tell you, if you would be wondering why eradicate extreme poverty and promote gender equality is here, the reason is because we have partnered with the microfinance institution as a platform. Because these are the microfinance institution have a huge base, audience base in the rural setup. So these give us achieve large-scale outreach, a group-based delivery mechanism because they have a regular meetings, women, 40 to 50 women meet every week at the same time. We use this platform to talk about health, to teach them how we can prevent diseases, all those things. And these microfinance institutions have branches all over the rural area. So we use that as our centers. There is another one, close client relationship. This relationship is very important. I have a lot of other things to talk about this relationship. This is one of the most key point for success of any telemedicine program in rural area. Some of our partners and supporters, we have ISRO, we have our technology partners, Neurosynaptics, Prognosis, and others. We have based the concept on fortune at the bottom of the pyramid. How we work, we have 2 models. We have one as a mobile telemedicine, and we have rural centers, which is connected to hospitals. Services, we have provide curative services, preventive services through mobile technology. We have a lab in our mobile technology, and preventive and healthcare in the rural. We have regular health checkups, hygiene, and education program. We are trying to provide strengthen our government in the public health system. How management, how are we doing is, we have volunteers, we draw. At every stage, we see the community is participated. Be it designing, be it implementing, be it monitoring, everything, we involve the community so that is one of the key success which will really take you forward. We select 2 women from the local community, train them in public health, emergency care, telemedicine, everything, and then they are placed in their village again back. This is the process. I'm not going to go into detail of this, but I'm going to share how we go about functioning this. The starting of a selection of a center in rural areas, we do a village survey. We go to village and identify, we follow certain criteria like there are no doctors available, there's no healthcare facilities, all those things are considered, and we sit with the villagers and identify what is their problem, what do they require from us. Based on their feedback, we go and start the centers. Once we do identify that village, we train 2 women. With the help of the community, we select those 2 women. They really tell us who is really required. And they suggest the names, and then we select. And these women are not qualified persons. Maybe they're 12th standard pass, or sometimes we do get 1-year nursing student or something like that. We train them in nursing care, we train them in computers, and how to use telemedicine and all those. Next, and then we start establishing the center, and this is typically how one of our centers looks. Then inauguration, and we are really very proud to have Professor Dr. Abdul Kalam to come and inaugurate, and he has included this center in his Meenakshi Mission Pura project, and he really follows up how this center really functions. And I have to give every 3 months, every 6 months, how is the progress of this the center functioning. The clinic in action. In the rural area, this is the women. We have a pediatric case and a elderly women talking about. Consultation by doctors in our hospital. We have consultation, we have a regular physician who is sitting throughout the day, but whenever consultation required by specialists, we call the specialists and they come to our center and give the consultation. I'll share some of the statistics with you later. And once the consultation is done, prescription is printed out and given, and we have certain set of medicines in our rural centers, and otherwise we prescribe, and they take it from the places. This is again a key important point, like we have a house visit and data collection. Why is this required? Maybe because we come from a public health background, we are giving more importance to this. No, this is really helping us to connect to the people in the rural village. We know, we identify what is the problem over there, and based on their problem, we try to give a solution. We try to, okay, let's say that in the village we have a lot of gynecological related problem, and then we give these health workers education, how they have to talk, what needs to be told, how they can prevent all those gynecological problem, and help them if they have any queries. These health workers come back to us, or we have a group meeting, and in that meeting we actually give them a solution. Another important thing which happens is follow-up. Rural women, or take it anybody, they don't have compliant to the medicine. They don't adhere to the medicine. So like we give for 5 days, they just take for 1 or 2 days and then leave it. This really helps us to follow up that they continue the medicines for the next 5 days. And once you go and talk, how are you? You know, they are really feeling better. I'm feeling better, but we tell them you have to continue, but they say, why do we have to continue? No, we have to continue. And this feel-good effect is more important for success of your telemedicine project. This is how we use the microfinance. This is, in one side, you can see these women have come for collecting their loans, and we talk about health. And the other, in the regular group meetings, we talk about health to them, how to prevent certain diseases. Every month, we talk about one particular disease. How it works, this is a video. I think I should not be playing the video. It's actually what you have seen in the photo that's there in the video, because it's short of time, I'm just cutting off that. This is our mobile telemedicine camp. This mobile telemedicine has got all the facilities inside the van. We have X-ray, ECG, whatever, ultrasound, everything is there. We go into remote villages and conduct the camp with the help of satellite connectivity. Like we conduct at least around 5 to 6 camps in a month, which is around 150 to 200 patients we do. And this is for specialty. Sometimes we do as a general camp, sometimes it's a specialty, either cardiology, gynecology. We do a lot of marketing for this and get it done. And this is completely free, which we do it. Okay, some of the statistics. Totally, till today, from the time we have started in 2008, we have seen almost 14,000 patients. And if you see the graph, I have put it in quarterly, it has been going on. And if you see, there's a dip in between in one of the quarter. We were trying to identify why this dip was there. The care is there, everything is there, the same patient, same population, why this dip? Here's the personal touch which is coming. In between, we had a change in our, in our staff, which really made the difference. We went to the community and asked, what is the reason that you're not coming? What happened? They said, sir, your doctor before who was there, he was so nice, he was talking to us. Now this doctor does not talk to us. This is what the villagers need. If you want a telemedicine to be successful in the rural area, you need to have a compassion from the doctor's side. You need to talk to them. They have, see, everybody is giving crocin for a fever, but why somebody is going to a particular doctor? It's because his compassion towards the patient which is bringing them. And then once we rearranged it, again it started growing. This is what which I wanted to stress more here. The human touch is more required. Even though we are talking about technology, it's not touching the patient, but how we talk is more important. That is what they require. Some of the statistics which we have observed, all the cases, like we have 60% of the new cases and 40% review. The male, 70% is the female population because we are working with them. At no point of time, we are not restricting anybody, but 70% are the females. Age group, we have all age group, pediatrics, majority are 30 to 60%, 60 age group which we are getting. Diseases, this is some of thing which as a public health person I always try to understand what it is. If you see 68% of the women who have come are anemic. 68% in the village who have come are anemic. And diabetes over 45%, hypertension 35%, and it's basically for the common cold, fever, joint pains and all those things which patients are coming. Be it pediatric age group or any age group, this is what the majority of the problem which we have seen. And all these things do not require any specialist doctors. I have another slide which talks about, and joint-related problems 22% because we have almost 10% about old age people who are there. Emergencies, only 3%. Whatever we have seen in 14,000 cases, only 3% it be cardiac emergency or injury or an accident, it's only that. And then other complaints which we have seen. Observations on referrals, 40% of the cases required a specialist opinion. Specialist opinion in the sense it's not by the GP, either it could be gynecologist or it could be diabetes or it's a pediatrician or something like that. And investigation, only 16% of these cases required higher investigations. Higher investigation, that means what I tell is either it's an X-ray or ultrasound or be it any kind of blood investigations, that is what it is. Referrals, 6% of them required a referral to a higher center. That's all, only 6%. And 94% we could handle it there. An actual visit of the persons who we have referred, it was 60%. The rest of the 40% did not go. I just wanted to share one of the experience, one woman which we are taking care. She really has a diabetic foot very bad, which is in the gangrenous state. We told her you have to go to a higher center and get either we need to do a procedure or something. She tells, no, my son doesn't want me to take me there. How do we do? Even if I die, you treat me, that's all. So we took up a challenge and we saw, let's treat this person. Even she's not ready to go, and we tried. And today her leg is really very good. It took almost 3 months to cover that, but every day we did dressing and this really helped. But this is what we get a satisfaction. And even in emergencies, cardiac emergencies, we had one of the person who come, he was almost, he just came for checkup, I'm feeling very weak, and we identified, we just took an ECG, and it was an acute MI. Immediately he was transferred to a hospital, and he was done, an angiogram, angioblast was done, and he was saved. These are some of the key examples which we have. Procedures, only 4% of the patients required some procedures. And this we are covering almost, we are doing it with the 4 of our centers, and we are covering almost 90 villages. Around 90 villages people are covered in this. And people have to travel, sometimes there is no buses, one of the village, the bus goes only twice a day, once in the morning and once in the afternoon. These are the only available transport available. We have had patients who walk 5 kilometers and come there just to take the consultation. I do agree there are a lot of PHCs nearby, but even then they are coming here. We go to a place where there are no PHCs or any other health facilities in the nearby area. Social impact, we are trying to bring in high impact in health, which in turn would bring in the quality of life. Rural population are getting affordable treatment. We encourage to join health insurance programs or risk pooling because we have tried to work with the microfinance institution. In general, this really helped us because if you see in Indian health system, indebtedness because of health is more, they are going into poverty because of health reasons. That is what we are looking into that. Probable factors for our success, which we see could be because we are reaching the unreached. Thank you. We have accessibility we are trying to provide. We are trying to provide quality and time services. Trust. This is one of the most important aspects which I would give importance to, trust and relationship. Low cost, affordable. It doesn't mean that in the technology low cost, but the low cost to the people. See, if we have the technology which we are investing so much money, if I have to, our investors will tell what is ROI if you are not giving that kind of low-cost solution. Because another thing is informed choice. Leave it to the community. What they want, they will take it. If you go and give it to them, they are not ready to take it. We just worked out a cost benefit, what would be in a general and a telemedicine, what we are trying to provide in this Meenakshi Telecare. Like fever, consultation, you have basic investigations and all, what we are charging is 10 rupees. If it's a conventional convention, it's going clinic, it goes beyond 100 rupees. This is what really helps the patient in the rural area who even just get only 30 rupees a day for their earning. Their family income is 30 rupees a day. Some of the key challenges, cost effectiveness, low cost solution, Availability of committed doctors. This is one important thing. You need to be human. Treat patients as human. That is what I got the feedback from the patients in the rural community. Initial investment is very high. Connectivity is a problem. Power in remote areas we are trying to manage somehow. And financial support till the sustainability of the project. And I'm sure that we all are talking about sustainability. If we have a low cost and if we work on volumes, definitely it will be sustainable, because we have come to a stage where I have seen that we could really reach a break even if we go in terms of volume. Today we are seeing almost 35 to 40 patients a day. If we do it, and with the cost what we are charging, we would really reach the break even. Thank you.